Hello, everyone. Good morning, evening, afternoon, wherever you are joining from. Welcome to the 15th webinar of ReSVINET's webinar series. My name is Roxy and I'm a member of the ReSVINET Foundation. I will be introducing our host for today and just give a small instruction. Today's host is Harish Nair. We're very happy that he is here today to guide this webinar. Harish is one of the founding members of one of the founding board members of the ReSVINET Foundation, and he is a chair of pediatric infectious diseases and global health at the University of Edinburgh. Now, one small instruction for today is that we would be very happy if you could participate in the discussion. We have a presentation today and then a Q&A session. On the top of your screen, you find a Q&A button that you can use to submit your question. So I hope you enjoy the webinar today, and I would like to give the floor to Harish.
Thank you, Roxy, and thank you all for joining the webinar. So it's my pleasure to host this today. So I'll briefly talk a bit about ReSVINET Foundation for those of you who are unfamiliar with what the foundation is all about and what do we do. So we are more than a decade old now, and our vision and mission, which were set up more than 10 years ago now, continue to be relevant. So our goal is to connect global expertise and leadership in order to decrease the global burden of RSV infection. And our mission is to support the performance of high quality research, to improve the knowledge of RSV epidemiology, and to develop safe and effective therapeutic and preventive interventions. And we're very glad that that particular goal of ours to have safe and effective preventative interventions have now got to fruition, and we now have several products in the market that have been licensed and in fact have been administered to both the young infants, also to the elderly last winter. And our goals are to advocate and create awareness for RSV disease, to act as a focal point for effective partnerships with stakeholders, and to combine knowledge and capacity required to enhance the development of novel RSV therapeutics. So why do we need to do RSV research and education? As you know, particularly in a lot of the settings, amongst the various different stakeholder groups outside the pediatric community, the knowledge of RSV is rather limited. More so in the elderly, but also continues to be for the pediatric age groups. And as you would all know, that we've previously estimated that in the year 2015, there were about 33 million cases of RSV, of which more than 3 million were hospitalized, and there were about 120,000 deaths, and half of these were in children younger than 6 months of age. So very important cause of morbidity and mortality in very young children, and particularly in temperate climates, it is the leading cause of hospitalization during the winter months. And in settings like Galicia, where an intervention has been implemented last winter, it's shown that there's more than 60% reduction in all-cause hospitalizations. So really, you know, the vaccines and the interventions have the potential to make a dramatic impact on our healthcare systems. So the ReSVINET webinar series have a couple of objectives. The first is to promote knowledge sharing of the latest developments and publications. Particularly, we want to share with everyone the groundbreaking studies. And also, this is an opportunity to educate professionals, particularly our early career researchers in the field of RSV. So we try and do this about on a quarterly basis, more or less. And we've had, as Roxy said, 14 webinars so far. This is the 15th webinar, and this is on average been viewed by at least 250 participants. And we've got a very high satisfaction rating. Overall experience has been rated as 4.8 out of 5. And also in terms of interaction quality, again, very highly rated, 4.8 out of 5. The viewership is globally representative. We have viewership from 46 countries across the 5 continents. So today's webinar is on the RSV disease burden during the COVID-19 pandemic. As you know, that with the emergence of the SARS-CoV-2 virus, there was a complete change in the in the landscape of respiratory viruses, and also the non-pharmaceutical interventions that were put in place. So what happened in different parts of the world and what lessons can we learn from this? This is what we're going to hear today from Professor You Li, or he's also popularly known as Leo. He is a professor of epidemiology at the Nanjing Medical University in China, and he's also an honorary fellow at the University of Edinburgh. He leads the Infectious Disease Epidemiology and Modeling group at the Nanjing Medical University, and the group conducts research on disease burden, transmission, and prediction of respiratory infectious diseases, as well as assessment of the impact of pharmaceutical and non-pharmaceutical interventions. Leo has a substantial track record in publishing in leading medical journals like the Lancet, Lancet Respiratory Medicine, Lancet Infectious Diseases, Lancet Global Health, Lancet Digital Health, Eurosurveillance, and PMC Medicine, amongst others. And he has received the Overseas Distinguished Young Scholars Fellowship funded by the National Natural Science Foundation of China, as well as several research grants from international organizations and pharmaceutical industries. And while he was doing his PhD here in Edinburgh with me, at the end of the PhD, he won the Kerr Memorial Prize. So I'm very delighted, Leo, that you could take the time today to share with everyone your very important findings that were published recently in one of the Lancet journals. Over to you, Leo.
Thank you, Harish. Let me share my screen. So hopefully you can see my screen now. Good morning, good afternoon, and good evening. It's my honor to be here and to present some of our works regarding RSV disease burden during the COVID-19 pandemic. And here is my disclosure of competing interests. So before we start with the topic today, I would like to take some of the time for the presentation to kind of go back and to have a recap on what was the RSV disease burden like before the COVID-19 pandemic. So here, this is, to start with, this is the recently published study by our group, which look at the full age spectrum of RSV hospitalization burden. And this is based on the published studies that modeled the RSV hospitalization and the mortality burden using a statistical approach. This is more or less based on the excess hospitalization or the excess mortality approach. So basically, so this slide shows the age distribution of RSV hospitalizations in high-income countries across different age bands here. As you can see, overall, there is a U-shaped age pattern in terms of RSV hospitalization rates. And if you note the y-axis here, this is log-scaled hospitalization rate per 100,000. So it means that if there is 1 unit of difference, then this means that there is a 10 times difference. So basically, we can see that infants had the highest RSV hospitalization rates, and followed by the older adults age group, as well as young children aged between 1 year old and under 5 years. And similarly, we also look at the RSV mortality rate across different age bands, but this time we managed to include studies from both high-income countries in blue here and upper middle-income countries in red here. As you can see that we could see a similar U-shaped age pattern, but if we compare between the two income groups, there were subtle differences. So let's look at upper middle income countries first. The highest RSV mortality rate was actually in the infant age groups, and followed by the over 75 years of age. But if we look at high income countries, it is the older adults over 75 years that had the highest RSV mortality rate, which is different from the upper middle income countries. So this is the overall RSV hospitalization burden by age. And next, let's zoom into the first year of life. Obviously, we can see infant age groups had the highest RSV hospitalization and the mortality burden. So here, this is a work that's just been completed but haven't been submitted. This is part of the PROMISE project, where we look at the proportion of RSV hospitalizations by months of age among infants. So, and this is, and we kind of synthesized the proportion by the country income groups. So we can see consistently for all of the three country incomes, high income countries, upper middle, and the lower middle income countries, the second month of life had the highest RSV hospitalization burden. And from that age, moving to the older age groups, there is a declining curve there. And for the year of 2019, we estimated the RSV disease burden by looking at different outcomes, and we compared the across different income strata. So we start with the RSV related associated acute lower respiratory infection incidence in the community, and here we use infants as an example. We show that there were about 12.88 million episodes of RSV incidence in the community. And here in low and middle income countries, they accounted for over 96% of the RSV incidence. But here, as you can see, LMIC is only accounting for 90% in terms of the population. So obviously, this is a disproportionately higher RSV incidence in a community in low and middle income countries. And then moving on is those LRI cases that need hospital admission. So we estimate that could be around 3.8 million episodes, in which 97% occurred in low and middle income countries. So it's even higher than the community incidence. And moving further, and quite interestingly, we show that overall there were 2.2 million RSV-associated hospitalized cases. But here, if you look at the proportion of these hospitalized cases in low and middle income countries, this only accounted for less than 90%. It's 87%. So this is an interesting finding. It just indicated that low and middle income countries had a higher RSV incidence and a higher proportion of LRI that needs hospital admission, they actually had a lower hospitalization rates, which obviously showed that access to hospital care was quite limited in low and middle income countries. And this could also be reflected in the in-hospital mortality estimates, where we could see 98% of in-hospital deaths occurred in low and middle income countries. And also for overall mortality, which is the total of in-hospital and out-of-hospital mortality. And the percentage is even higher, which is 99%. And this slide just is a further step, and which tries to show the higher incidence in the community versus a lower hospitalization rate in low and middle income countries. And here we focused on the same infant age group, and we calculated the rate ratio between the RSV community incidence, which is shown here, and the RSV hospitalization rates. So basically, we can see that in low income countries, the rate ratio is the highest, meaning that the proportion of RSV LRI in the community, was lowest. That being admitted to hospitals was the lowest amongst the 4 income groups. Whereas in the high income countries, the rate ratio was the smallest. Again, reinforcing the fact that the access to hospital care was limited in low and middle income countries. And we also went a step further by looking at the out-of-hospital deaths versus in-hospital deaths in low and middle income countries. And for this slide, we focused on infants aged under 6 months. And we showed that in low income countries, the in-hospital case fatality ratio was higher than the lower middle income countries, and was also higher than the upper middle income countries. And for the case fatality ratio in communities, that's the same case. And we could also see the case fatality ratio in the communities was higher than the in-hospital case fatality ratio for the low-income country, just as expected. And the reason behind that was, again, the limited access to hospital care. So in the unfortunate case, a substantial number of RSV-associated, acute lower respiratory infections in the community, these children died out of hospital just due to the lack or the absence of access to hospital care. And we also estimated the ratio between in-hospital and out-of-hospital deaths. And we found this really astonishing number, astonishing ratio, like for every one RSV in-hospital deaths found in low-income countries, there were as many as 4.6 out-of-hospital deaths due to RSV in the community. So with that, with the background, now we can move on to the RSV disease burden during the COVID-19 pandemic. So as Harish just mentioned, with the implementation of non-pharmaceutical interventions, since the COVID-19 pandemic, the RSV circulation was largely interrupted, and this was often followed by an out-of-season resurgence in many countries up to today. So here we take United States as an example in the Northern Hemisphere. And before the pandemic, we can see that RSV seasonality at the national level is quite stable, which is shown in the blue lines here. So the season started in October of the year and then ended around March to April the next year. However, after the beginning of the COVID-19 pandemic and with the implementation of NPIs and followed by the relaxation of NPIs, there was an out-of-season RSV resurgence in the season of 2020 to 2021 here, as you can see at the right end of the figure. And this out-of-season resurgence continued to the next season, where during the summer months, which is part of the 2021 to 2022 season, and it ended just right before, when a usual RSV season started. So it's a really out-of-season resurgence and out-of-season RSV activity there. And what's interesting here is that in the season after, which is the season of 2022 to 2023, we can see that the season is closer to the normality, but is still distinct from the normality. It's still earlier than the usual season, but later than the previous season. And the same out-of-season resurgence could also be found in the southern hemisphere. Here we use the Australia as example, the data from the New South Wales respiratory surveillance reports, where we could see an out-of-season RSV resurgence in later 2020, which is outside the normal winter season, as we can see in the purple curve here. So with that in mind, let's now look at what is the RSV hospitalization rate like during the COVID-19 pandemic. So here, this is, we conducted a systematic analysis of RSV hospitalization burden during the COVID-19 pandemic. And because of the irregular RSV circulation during the COVID pandemic, rather than calculating like the RSV hospitalization burden for the year of 2020, for example, or 2021, we used a 12-month moving annualized RSV hospitalization rate to show the time varying changes in RSV hospitalization burden, while canceling off some of the seasonal variations across different countries, by looking at the 12 months interval. So here we look at these 5 different age groups, and we used the year of 2019 as the reference, which is shown in the dashed lines here for each of the age groups. So we can see that after the beginning of the COVID-19, in the year of 2020, the hospitalization rate decreased over time. And in the late of 2020 and early of 2021, the hospitalization rate started to increase. But there was an asynchrony in the changes of RSV hospitalization rate. For example, if we look at the 3 different income groups, we can see that the high-income countries, they had the most rapid increase after 2021 in terms of RSV hospitalization rate, and the hospitalization rate was almost comparable to the pre-pandemic reference, the reference of 2019. Whereas in the lower middle and upper middle income countries, the RSV hospitalization rate was still substantially lower than the pre-pandemic level as of around January 2022. So that's the first difference there. The second difference is about the age group. So let's take a look at the high-income countries in green, whereas we see the RSV hospitalization rate for the younger age groups was slightly lower or quite similar to the pre-pandemic level. The RSV hospitalization rate for the older age groups was well above the pre-pandemic level. So it seems that the RSV hospitalization rate in the older age groups was higher than the pre-pandemic level. So we conducted statistical tests for the changes in the age distribution of RSV hospitalizations. And we could see statistically higher proportion of RSV hospitalizations in 12 to under 24 months, which is the second year of life. And this is probably, due to the fact that, infants were born in the early phase of the pandemic, which was largely in the year of 2020, because of the COVID-19 pandemic related non-pharmaceutical interventions, they were not exposed to RSV infection as their, as they did for their, as for the, those who were born, for example, in the 2019. So they remained naive to RSV until the relaxation of non-pharmaceutical interventions in their later life. So the susceptibility of this particular cohort was relatively high, and which explained why we could see a higher proportion of RSV hospitalizations in the older age group. And in some of the publications or some of the news pieces, you can also see someone coding this as the immunity debt. And we also conducted a statistical test for the changes in severity of RSV hospitalizations. And we observed a lot of variations across different reports from different countries. So overall, at a global level, we didn't observe any statistically significant differences in terms of severity, which is defined as receiving mechanical ventilation or being admitted to ICU. And although this is not directly relevant to the COVID-19 pandemic, there have been rapid advancements during the COVID-19 pandemic in the field of RSV immunization products, such as the maternal vaccine and the monoclonal antibodies for infants. So in the third part, what I would like to show very briefly was around the RSV disease burden after the implementation of infant RSV immunization, and taking some of the real-world effectiveness study. So the first study, which was recently published in the Lancet Infectious Disease, was a real-world study in Galicia of Spain. So basically, the recommendation was for 3 different groups for monoclonal antibodies. So for the program actually started in September 2023. So they had the first group, which is called the seasonal group, which aims at those who are born during the RSV season, which is September to March next year. And the coverage was pretty much high, it's about 92%. They also had a catch-up group, which immunized those who were aged 6 months or less by the time of RSV season onset, which is September 2023. Again, the coverage is about 90%, pretty much high. And also they had a high-risk group, which focused on the older infants or children aged 6 months to 24 months with high-risk factors in September 2023, and the coverage was the highest, which is 97%. And with such high coverage, we can see very clear differences between the vaccination group and the non-vaccination group in terms of RSV hospitalization rates. For the non-vaccination group, the RSV hospitalization rate was 19 per 1,000. If we compare this number to what we estimated before the COVID-19 pandemic in high-income countries in infants, these were very much similar, 19 per 1,000 versus 22 per 1,000. So this means that this season, the season of 2023 to 2024 in Spain, in Galicia, was like a normal season comparable to the pre-pandemic. So under this so-called normal season, if we look at the vaccination group, the RSV hospitalization rate was only 3 per 1,000. And this was very much lower than the infant RSV immunizations, and it's only slightly higher than the older, children aged 1 to under 5 years in high-income countries, 3 versus 2 per 1,000. And the overall effectiveness is very high, which is 82%. And here, this figure is quite interesting, and this shows the RSV hospitalizations among infants versus hospitalizations in children in their second year of life. So here, before the implementation of RSV immunization, either before and after the COVID-19 pandemic, we can always see that the right line is well above the blue line, which means that obviously the infant should have higher RSV hospitalization rates than those in their second year of life. But during the most recent season, with the vaccination in the infant age groups, for the first time, we could see that the RSV hospitalization rates in the infants, actually, they were lower than those in the second year of life, who most of whom were not eligible for the monoclonal antibodies. And this is quite interesting and quite exciting to see. And also another example in Luxembourg, they had the similar recommendations for the for nirsevimab immunization. They had the seasonal group for all the neonates who were born during RSV season from October to March, and they had a so-called catch-up immunization, capturing a little bit further than what Galicia captured from January 2023 to September 2023, and they also had this the high-risk group, and which included up to the age of 2 years. And the overall coverage was also high for the neonates. The coverage in maternity wards is about 84%. And we can see from the figure as well, there have been substantial changes in the age distribution. The mean age became older in 2023 compared to 2022. And also in terms of the proportion of under 6 months in 2023 versus 2022. And for severity as well, the mean length of stay was substantially lower in 2023, which is 3.2 days and versus 5.1 days in 2022, and also the proportion of those being admitted to PICU, 6% versus 9%. So to summarize, we could see regional disparities in RSV disease burden across different income strata, and we could clearly see that there is this high incidence, low hospitalization, and high mortality kind of phenomenon in low and middle income countries. And such regional disparities became even more pronounced during the COVID-19 pandemic, as we could see that high-income countries, the hospitalization rate of RSV increased more rapidly than the middle-income countries, and this is possibly due to a persistent negative impact of the COVID-19 pandemic on the healthcare systems or the healthcare access in the low and middle-income countries. And from the real-world effectiveness study, we could imagine that such disparities could be even more pronounced after some of the high-income countries started with RSV immunization programs for infants, either maternal vaccine or the monoclonal antibodies. And this disparities and also the likely more pronounced disparities, emphasize the need to introduce RSV infant immunization in low and middle income countries. And of course, there are remaining questions. For example, in terms of the knowledge gaps, we could see that there are still lack of data in RSV disease burden in community in low and middle income countries or in adult age groups. And also, we need to think about what's the best RSV immunization strategy in low and middle income countries. And in the medium to longer term, we also need to see whether there have been any changes both for the epidemiology of RSV and non-RSV respiratory pathogens following the implementation of RSV immunization. So are we giving the floor to other respiratory pathogens by preventing RSV, or are we seeing a more of a stable epidemiology, or the other way around? I think this remains to be found. And with that, I'd like to thank the rescue and the Promise members who support a lot of works that's presented here, and also WHO and the Gates Foundation, and all members from the RSV Gen, which is coordinated by Professor Harish Nair, and also my team members at Nanjing Medical University. Thank you for listening.
So thank you, Leo. Thank you very much, and a very interesting presentation. While we wait for questions from the audience, maybe I can start off with a couple of questions. So what does this, after looking at the data for the current sort of winter season that has sort of just passed us, the 2023-24 winter season, what does it look like? Do you think that the seasonality has reverted to normal? And if not, when do you think we will revert back to sort of the normal seasonality?
Yeah, thank you for the question. I think this is, I mean, obviously from what I presented, especially for the case of the US, the RSV seasonality did not really return to the pre-pandemic pattern, but I can see there is at least a trend that this is kind of moving back to the normality, so to speak. And speaking from the local context, so we published a study, an analysis in Beijing this year, and we compared the RSV seasonality after the COVID-19 pandemic, the different seasons. So we could also see a trend like back to the normality. So I think, but looking at the data from different parts of the world, I can see the progress towards to normality is varied. In Australia, we could see that this is more or less similar to what we observed before the pandemic. So here, this is a short line here, this short black line here. This is the 2023 season. So at least from the beginning of the 2023, it looks like that we are going to have a normal RSV season in Australia, at least in SW. But in other countries, there may be things could be slower. But overall, I could see that this is not going to take long. As the population behaviors, as well as other aspects like the impact of the COVID-19, these are all back to normality. I think it's just a matter of time. Although we are not 100% sure, like it will return to a complete normality as before, but at least I can see the trend here to normality.
Right. Thank you. So what do you think drove the change in seasonality? Is it the emergence of a new virus, or was it non-pharmaceutical interventions that were put in place, or is it something else?
Well, I think obviously at the beginning of the COVID-19, it's the non-pharmaceutical interventions that played a major role in driving the circulating patterns of RSV. But after that, I think it is more or less the dynamics of the population susceptibility that drives the RSV circulating patterns. But I think here we should also not ignore the role of possible viral interference or the virus or pathogen interactions. I think this could also play a role, as we previously showed that the 2009 influenza pandemic, obviously it delayed RSV season by several weeks. So this kind of pathogen interaction could also play the role here. Although the exact effect of the interaction, I think this is largely unknown or is understudied, and I think this is really a field that we should explore. And with a new member in the community, which is SARS-CoV-2 in the virus or the pathogen community, I think this could reshape the circulating patterns of many respiratory pathogens. Like they may found a new kind of like a balance, in terms of the timing or the patterns of circulation.
Thank you. We now have questions from the audience. So one question is, do we know anything about the RSV burden in older adults during the COVID-19 pandemic?
Yes, I think there were, although I would say if you look at the amount of evidence in terms of RSV disease burden in the pediatric age group and the older adults, obviously there was still very limited evidence for the older adults age group. I think part of this challenge was about the testing practice. And also I think the COVID-19 pandemic obviously had a greater impact on this age group compared to the pediatric age group. So anyway, so there was little, relatively sparse evidence on that. But again, I think speaking from the local experience, we did in the study that I mentioned in Beijing that we published in the Lancet Regional Health Western Pacific, what we did observe was that the disease burden of older adults was lower than the pre-pandemic level during 2020 to 2022. This period was the period when Beijing had really strict COVID-19, related non-pharmaceutical interventions. But after the reopening, still we didn't see really, in terms of the RSV positivity proportion compared to the pre-pandemic, we didn't see like really higher than usual positive proportion. We could see still a kind of relatively smaller RSV positive proportion. And quite interestingly, Beijing had a year-round RSV activity during the year of 2020, and then out-of-season RSV activity in 2023. And during both epidemics, there was very low RSV positive proportion in adults, but the positive proportion of in the pediatric group was high. So I think this was not seen in other settings, and which is interesting to see. I think this may be related to the immunity test that we talked about earlier, because adults they had some immunity more or less compared to the infants. They are less impacted by the lockdowns or by the non-pharmaceutical interventions. So that's the kind of the data that we could observe by now.
Thanks. Another question is, what do you think would be the age shift in the age patterns after the pandemic, like you've observed? Do you think there will be a similar shift in age pattern after the RSV interventions are implemented?
Well, I think this is a really interesting question. I think this is what people would be interested most especially after implementation of RSV immunization in the first year, as we observed in Spain and other countries. I think if I recall correctly, there was a a study that I think that's part of the clinical trial. Is a follow-up that looks at the or compare the RSV incidence between the vaccination group and the non-vaccination group. I don't think there was evidence that shows that being protected by, for example, the monoclonal antibodies in the first year of life would increase the risk for being infected with RSV in the second year of life. So if that's the case, then I would not expect to see an age shift in terms of the RSV cases after implementing the RSV immunization.
Right. The other question that we have is, just give me a minute, this just disappeared from my screen, is do we have a specific case definition for the RSV suspected cases, or are we relying on the WHO ARI case definition, as fever is not a common form of presentation with RSV?
Yeah, so that's a good question. So in our studies, we did not restrict ourselves to, for example, the WHO Li definition or the SARI definition, which required the presence or history of fever. So, and we previously, I think there was early publication showing that if we included fever or history of fever, then that would have missed a substantial amount of RSV infection. So that's the reason that we didn't use the Ely or SARI definition that's it was initially intended for the flu surveillance.
Right. Another question is, do we know what's the sort of predominant RSV subtype that is circulating in the adult population in 2023-24?
So we we don't have global data on this, but in Beijing, we observed subtype B being more predominant during the COVID-19 pandemic, which is slightly different from the pre-pandemic, whereas we often see RSVA being predominant in Beijing. I think it's like maybe 2A predominant season followed by 1B. But after the onset of COVID-19, there were more RSV subtype B being predominant in the post-pandemic seasons.
Right. I had one question around, do we have any data on the timing of the infection in the older adult population vis-a-vis the infant in any given sort of geography? So is it that both the older adults and the young infants get infected at the same time and the infection peaks at the same time, or is that in one group you find the infection appearing earlier?
Yeah, I think that's an interesting question. I myself don't have the data, but I'm aware that there have been recently a publication by John Paget's group, which used RSV surveillance data and compared the timing of circulation among different age groups. I think what they showed was that the school attending children was the age group that had the earliest RSV infection, which was followed by the extremes of age, the younger children and the older adults. I think that's what they found in their analysis.
And some of the high-income countries are now going to start introducing vaccines, maternal vaccines or monoclonal antibodies, more so, in this sort of coming winter. Do you think that RSV will cease to be a public health problem in the geographies where the vaccine is implemented?
Well, I think yes. So I mean, obviously what we have observed up to now is that in the real world effectiveness study, these RSV prophylactic products, either for infants or from clinical trial for older adults, they have been effective or efficacious. But I think we are just at the year one of the implementation of RSV immunization. I think we should be cautious around jumping to the conclusion that RSV ceased to be an important pathogen related to NRI. I think we should observe, or at least follow up for a longer period, and then to see what are the changes, what are the medium to longer term changes in RSV epidemiology, and also the epidemiology of other related respiratory pathogens, what are the changes are like, and then we could be a better place for a conclusion.
Right, and if in geographies and countries where the monoclonal antibodies are being implemented, do you think with this widespread implementation of long-acting monoclonal antibodies, we are going to encounter some sort of resistance to RSV in those populations?
Yeah, I mean, this is a good question. I mean, in theory, this could happen. Especially for monoclonal antibodies, I think that's the odds are are there. I think that's why it's important, especially for countries that have introduced monoclonal antibodies and then RSV vaccines, to continue monitor the possible resistant strains of RSV. To kind of really help guide the immunization, also perhaps guide the further development of RSV prophylactic products.
Thank you. So that's all we have time for in terms of questions. Thank you to all the people who have logged in to this webinar. Thank you for posing interesting questions, and thank you, Leo, for the very interesting talk and taking all these questions. I now hand you all back to Roxy. Roxy, over to you.
Thank you, Arish, and also thank you, Leo, for both of you for a wonderful webinar. I had one last request to our attendees. I will launch a short survey in this meeting, and we are always looking to improve. So it would be very valuable to us if you could fill out the survey and let us know what you think of the series and of this webinar in particular. So thank you very much. I will wait for some answers to come in before ending the meeting. And have a good rest of your day.